case is one of a 62-year-old man who had been feeling well until several months before he presented to his primary care physician with complaints of significant fatigue and night sweats. When he was seen by his primary care physician, he was noted to have an elevated white blood cell count of approximately 100,000 with an absolute lymphocyte count of around 82,000. He was also found to be slightly anemic with a hemoglobin of 11.2. His platelets were normal at 190,000. He, on physical examination, had multiple lymph nodes that were enlarged. This prompted the primary care physician to refer him to his community oncologist, where he underwent an evaluation for chronic lymphocytic leukemia. The oncologist sent his peripheral blood for flow cytometry, which revealed a classic immunophenotype for CLL. FISH testing revealed an 11q deletion. He also sent the mutational status of his immunoglobulin heavy chain, which revealed that it was unmutated. The patient had a normal LDH. Because this patient was symptomatic, he was started on therapy. The therapy consisted of ibrutinib and rituximab. I think this was warranted because this patient has two symptoms. One, he was anemic and he had night sweats and significant fatigue that prevented him from doing many of his normal activities. The normal triggers for initiating therapy include anemia, thrombocytopenia, rapid doubling of white count to the point that within 6 months the absolute lymphocyte count is doubling in a very short fashion. Huge lymph nodes. And by this I mean not just a 1.5 centimeter lymph node, but massive lymph nodes, 5 to 10 centimeters, massive lymph node, a large spleen that's palpable and below and progressive in nature. In addition, anemia is another reason to treat patients. The reasons that we treat patients today are the same as the reasons that we treated patients 10 years ago. Those indications really haven't changed.